Welcome to the third episode in the Confronting Diabetes Prevention and Management webinar series, hosted by the Midwestern Public Health Training Center, HRSA Region 7. The Midwestern Public Health Training Center and 9 other regional public health training centers, 39 local performance sites, and a national coordinating center are all funded by HRSA to make up the Public Health Learning Network, which is educating professionals and elevating practice. We've partnered with the Association for Public Health Nurses to present today's webinar. And this is Lori Walkner, coordinator of the Midwestern Public Health Training Center. Today, we welcome Abby Charles and her colleagues to present episode 3, the role of community health workers in collaboration with public health nurses. Abby Charles is a senior program manager at the Institute for Public Health Innovation. She provides leadership and coordination for community health worker initiatives, managing a network of peer community health workers and a portfolio of programs that address cross-jurisdictional policymaking and information sharing, program refinement, implementation, and evaluation. Ms. Charles provides oversight to a portfolio of about 10 community health worker-based health service programs, each of which provides a combination of screening, outreach, health education, disease self-management support, referrals and navigation to health and social services, and one-on-one support to well over 1,500 individuals, many of whom are Medicaid and Medicare beneficiaries. Their Institute's program focuses on cardiovascular health, diabetes, HIV and AIDS, hepatitis C, and reproductive health, as well as one that cuts across health areas. Many of their programs focus on integrating CHWs into a clinical care team, which often includes nurses, case managers, and other licensed professionals. The Institute also provides training on team integration. So we're happy to have Abby and her colleagues presenting today. Just a quick note before we get started. We'll be collecting questions via the chat box function at the bottom of your screen, and we'll answer those questions following their presentation. So at this time, I'll turn the program over to Abby. Abby, please take it away.
All right. So good morning, everyone. My name is Abby Charles, and as we heard, I'm the Senior Program Manager for the Institute for Public Health Innovation. And I'd like to first acknowledge our sincere appreciation to the Midwest Public Health Training Center and the Association of Public Health Nurses for this tremendous opportunity to share this exciting work that we're going to talk to you about for the next hour. First, I'd like to give a brief overview of the Institute for Public Health Innovation and how our partnership with the Richmond City Health District evolved. And then I'm going to pass it over to Stephanie Toney, who is the Resource Center Supervisor, Denise Wyse, who is our Community Advocate Supervisor, and Shantini Calvin and Shakita Taylor, 2 of our phenomenal community advocates, to give you more insight into our Community Advocate Program, which is a program run by Richmond City Health District in coordination with IPHI to facilitate linkage to care in communities. And we're really excited to talk about how public health nurses intersect with community health workers in this work. So a little bit about IPHI. We are one of 44 members of the National Network for Public Health Institutes, and we're the official public health institute serving Virginia, Maryland, and Washington, D.C. We have offices in Richmond, Virginia, and Washington, D.C. And we believe that all people should have the opportunity to thrive and live healthy and productive lives, regardless of who they are or where they live. And as such, we work collaboratively with partners in local communities across Virginia and the rest of our region to develop innovative solutions to complex health and social problems in order to promote health for all. Our work falls into 4 broad categories. We convene and facilitate cross-sector partnerships. We provide training, technical assistance, and workforce development, and serve as the Virginia performance site for the Mid-Atlantic Public Health Training Center. We support effective public policy to promote health, and we've also worked collaboratively with partners across the region to design, implement, and evaluate innovative public health strategies. Much of our work relates to advancing the community health worker workforce. Now, at IPHI, we've been involved in multiple aspects of community health worker workforce development. We've developed a comprehensive community health worker curriculum and trained over 450 community health workers in community health worker competencies in this region. We've worked with multiple partners in the region to develop models of care that utilize community health workers in collaboration with doctors, RNs, nurses, case managers, social workers, etc., and to address the social and economic barriers that prevent many patients from adhering to medical care, seeking primary care, receiving appropriate screenings and preventative services. We're also working with partners in Virginia, Maryland, and DC to define and formalize the community health worker workforce. Here in Virginia, we've worked collaboratively with the Virginia Department of Health to co-convene a statewide community health worker advisory group to guide the development of this important and growing segment of the workforce. And we've also worked with community health workers to build the Community Health Worker Association of Virginia, which is an exciting progress that we've had here in this region. As part of the work developing the workforce, we built on work that was done by James Madison University in 2005 and worked with the Community Health Worker Association and the advisory group to define what does the community health worker look like for Virginia. And this definition, for us, a community health worker applies his or her unique understanding of the experience, language, and culture of the populations he or she serves to promote healthy living and to help people take greater control over their health and lives. CHWs are trained to work in a variety of community settings, partnering in the delivery of health and human services to carry out one or more of the following roles: providing culturally appropriate health education and information, linking people to the services they need, providing direct services, including informal counseling and social support, advocating for individual and community needs, including the identification of gaps and existing strengths, and actively building individual and community capacity. So this definition is a melding of the APHA definition of the community health worker and this previous definition that was developed in Virginia. So what's distinctive about community health workers? For us, community health workers do not provide clinical care. They generally do not hold a professional license. Expertise of community health workers is based on shared life experience and often community and culture and shared culture with the people that they're serving. Community health workers rely on relationships and trust more than on clinical expertise. They relate to community members oftentimes as peers rather than purely as clients or patients, and they can achieve certain results that other professionals cannot. It's important to note that community health workers go by many titles depending on where they work, who they work for, and what they do. Some common titles include coaches, patient navigators, promotoras, patient educators, community health advocates, and peer educators. And here, with the Richmond City Health District, we call community health workers community advocates. So we're going to be hearing from our community advocates today. As part of our work with the Virginia Department of Health and the Community Health Worker Advisory and CHW Association, as we started to think about how to build out the community health worker workforce in Virginia, the first thing we sat and were challenged to do is to build out the scope of practice for community health workers. So in Virginia, community health workers serve in these primary roles: community mobilization and outreach, health promotion and coaching, service system access and navigation, care coordination and management, community-based support, and participatory research. And as we refined those roles to get to the core competencies that we saw community health workers needing for Virginia, we built out the following, which look similar to core competencies across our region and as well similar to national core competencies. So communication skills, cultural humility and responsiveness, knowledge-based skills, service coordination and system navigation skills, health promotion and disease prevention, advocacy and outreach skills, and professionalism. And we use these core competencies to build the trainings that we offer community advocates and community health workers in the region. And we utilize these as well as we think about, as we're hiring community advocates, what are some of these skills that we need to be looking for. Now, you might say that these skills and many of these roles look similar to sometimes what public health nurses might be doing in community. So we hope that through this presentation, we're able to define, through the work of the Richmond City Health District, how they have built out a program that really effectively utilizes nurses and community health workers and those skills in a complementary way. For us, why community health workers, why now? And this is my last slide before I pass it on to Stephanie. We have, community health workers have been around for a long time. In fact, likely since the beginning of public health. There are a number of reasons to be excited about the recent increased interest in community health workers nationally. There's the triple aim. So we've seen reduced readmissions, reduced unnecessary emergency room visits, evidence for increased screening and other benefits, reduced costs, and improved patient satisfaction as a result of the integration of community health workers. There are multiple studies that have shown positive return on investment for community health workers with an average of about 3-to-1 benefit, with some studies as high as 15-to-1 of the positive return on investment. Nationally, the Department of Labor has included community health workers as an official job classification. There's a growing number of states that are looking at ways to systematically define and develop the community health workers, including Virginia. And there are many other states that have gone before us, and thus in Virginia, we're able to learn from the successes and challenges of other states. And we found that to be extremely beneficial as we've moved forward with our work. And we've also found that CHWs can be a strategy for achieving population health and community development. Finally, with the Affordable Care Act, there's significant momentum building towards ensuring that community health workers are a recognized resource within public health and medical care systems, but much work needs to be done. And a lot of that work is what we're seeing happening at the Richmond City Health District. So I'm gonna pass it on to Stephanie Toney, who is the Resource Center Supervisor. She's a RN, BSN, and welcome, Stephanie.
Thank you, Abby. So the Resource Centers is a community health partnership in Richmond Public Housing Community. We call ourselves resource centers versus just clinics because we offer a plethora of other resources in addition to just clinical services. So we have a nurse practitioner, resource center specialist, community advocate, and housing advocate. So as Abby already mentioned, you'll hear us using the term community advocates. That's just the way we kind of summarize the community health worker because they are really advocates for their community. The satellite clinics are located in renovated low-income housing communities, and we aim to remove barriers, provide services, and connect, and invest. So removing barriers, there's usually a lack of knowledge, transportation, and trust. And so because we're in the community, we are aware of those areas that need additional awareness, and we need to provide that knowledge that may be lacking. Transportation, someone may say, I can't get to a doctor's office, or I can't link to the care that I need because I don't have transportation. And trust is definitely built. So I have a neighbor that we know her very well. That trust is built because we're there. We're dealing with the same things that you're dealing with because we are actually one of the units. We have neighbors. Providing services, so we offer health promotion, as well as prevention. We're connecting to local medical homes, and we're investing in Indigenous leaders who provide support to the community, which is definitely key in order for us to be successful, that investment piece. So training a trainer is so helpful to be able to continue this momentum. So the actual resource center space, like I mentioned, is an actual unit. And so we have transitioned the living room into the waiting area. The kitchen is a triage room where the nurse will do the initial triage assessment of the client. Then she'll hand the client off to the nurse practitioner who will see the client in the bedroom, which is the exam room. And so in the top left-hand corner, you'll see a picture of the outside of Creighton Resource Center. And in the top right-hand corner, you'll see Mosby Resource Center. Mosby is unique in that we have a 5-bedroom unit. So usually it's a 1-bedroom unit that we've renovated the space. Mosby is a little bit unique in that we have 4 additional bedrooms. And so we have changed those into office space. We have a computer lab. We also have a conference room. So that's really helpful for us to be able to provide additional services and connect. So our strategy, each resource center has a community advocate and housing advocate who focuses on community outreach, health and housing education, navigating individuals to medical homes, housing, education, and employment resources, and improving the community's quality of life by addressing social determinants of health. And so this model really lends itself to being able to provide holistic care. And so now I'm going to give it over to Shantini, who's going to talk a little bit more about who our advocates are.
Thank you, Stephanie. My name is Shantini Calvin, and from a community advocate perspective, we see ourselves as community liaisons, and particularly because we connect with our communities. We are also trained and have experience in the field of system navigation. It makes it easier for us to be able to service where we've already experienced certain situations. And we also collaborate with partners and fellow associates to strengthen our scope of practice and service. So in a summary, a community advocate is a person who comes from a diverse group of people. We have different skills, we have different values, we have different principles. However, we are also serving a diverse group of clients. With that being said, we are trained as leaders to understand barriers of our own neighborhoods and educate, motivate, and inspire others to make positive lifestyle choices. And I have my fellow Shakita Taylor, who is going to talk a little bit more about how she sees herself as a community advocate as well.
Hi, everybody. I'm Shakita Taylor. As a community advocate, what I do, I go out and do outreach, make sure to see what the community needs. And by that means a lot of people in the community we have to build our trust with them, because a lot of them don't have trust. It might take a while to get it, but we also try to figure out what they need as far as food, clothes, medical, any type of medical assistance that they need, as far as trying to get a PCP, get some type of insurance. Maybe they might have high blood pressure and don't have a way of getting no medicine. We try to help them get some type of medicine. And for me, I also do classes, which I also help them with learning about diabetes, healthy choice foods, exercise, which will be talked a little bit later. And I also help them, make appointments if they can't make appointments. Basically, I'm just their go-to person if they need help with any type of medical assistance that they need. And now I'm going to introduce Stephanie Tony again.
Thank you, Shakita. And so she spoke to community partnerships. She touched on several of these places that we already refer people to. And so it's not just the financial support that's needed. There's a list of those that financially support us. There's in-kind donations. There's medical homes that we directly refer to. So the in-kind support comes from RRHA, provides our unit. We don't have to pay utilities or rent, which is so in-kind for sure. It's so helpful to not have to think about, rent and, using the space is an in-kind donation from them. And then the medical homes, we have several agencies that we can directly link someone to that needs a primary care. Some of these are federally qualified healthcare centers that we can specifically make a phone call. We have somebody that we can directly link them to help them schedule an appointment. Community partners, there's a plethora of other areas that someone may have a need, and so we're able to connect with additional community partners. And then on-site providers, so Fan-Free and Minority Health Consortium help and come in monthly in order to provide free HIV testing. And so there's additional partners that will come in and provide specific services for us, to our clients. This slide is just to, in a very broad way, say the cost per patient. And so this is just a generic patient. It's not specific by type of diagnosis, but we have $1,200, over $1,200 for an ER visit. Primary care visit is $199, and the healthcare center is at $108. And so there's a lot of savings to the healthcare industry when we do preventative care at the healthcare center instead of letting people end up in the ER and utilizing it improperly for, I have a cold, and they just don't have a primary care doctor to go to, so they go to the emergency room. So community advocates and the public health nurse relationship is a wonderful coordination or collaboration between us. So we coordinate and navigate to the medical homes to address those social determinants of health. We're improving professional developments of the overall self-sufficiency of the community advocates, continuing to build them up as leaders. And we have relational and physical connections to see resources in public housing developments. So now I'm going to give it over to Denise for her to talk to more about that partnership.
Well, good morning. I'd like to introduce myself as Denise Wyse, who works for IPHI, but work at Richmond City Health District inside the Resource Center. My primary role there is to work with the community advocates to build up their self-esteem and to help them to really manage what it means to be a community health worker. I often tell them I cannot teach compassion. You have to come with it because you're going to need a lot of it out in this work field. I have worked with many community advocates to be able to accomplish the goals they need to with inside the community, especially meeting social determinants of health. We provide screening, we do health fairs, we do a whole lot of community activities. It is required of each community advocate to do at least 2 a month. So that leaves us a lot of time out in the community working with folks. And that they can identify us on the spot. I'm often in the grocery store and somebody says, "Hey, Ms. Wyse, how you doing?" Because they know we from work. So it becomes a really effort of us to really work well with the people who we work with at all of the resource centers. So the CAs are trained to do blood pressure and glucose screening. So those are some of the services that we provide when we go out to do health fairs. They're also, because my specialty is diabetes and self-management, they are given training as well on how to educate folk about self-management of diabetes. One of our partners conducted a survey in 2015, and they asked 2 questions that we felt that was very important to the work that we do. One of the questions was, do you know or do you think you have diabetes? And out of that 1,400, 800 people felt that they didn't know somebody or they felt that they had it. When we asked the question of, do you have diabetes, only 169 people replied yes. So that was a significant data for us to be able to know that we need to do some education about diabetes and how do you be able to diagnose that you do have it and then take yourself to the doctor. So being able to work with the community about some of their fears that they have with going to the doctor. So that was a significant data for us. CAs also provide linkage through education and support services. So we talked earlier about that they go out, they do outreach, they do door-to-door knocking. So they're either handing out a flyer or they're actually just going to see if there's a need that the resident or non-resident may need. They also have to do classes. So they get a lot of training. So we make sure that at least once a month we provide some training so that they are able to fulfill their educational obligations to the community. And we do utilize the tool from the CDC for conducting a pre-diabetes screening in the community. So a lot of time is not only spent at the resource center, but it is actually spent in the community, participating in community day, health fairs, and just an array of different opportunities that we get to service the community in which we work in every day. So now I'm going to lend way to Shakita Teller to talk about one of the classes that she's engaging in right now.
I'm engaging in the diabetes class that's with sponsor called Tricycling Garden, and we're talking about diabetes as far as making sure that they know the different types of diabetes, the difference between 1 and 2. We let them know the risk factor, the symptoms, and if it's not controlled with other complications. And along with these classes, it helps them know. We also teach them about eating healthy, grocery shopping. We do a game to let them know that if they go to the store hungry, like most people does, they wouldn't get nothing healthy. They'll go and get snacks, saying, that's not good for them. So we try to let them know what's the best way of spending their money. Also, as far as like the boil your food, bake, grill, not fry. A lot of us like that skin on our chicken, but we also have to let them know that some of that skin is not good, that we have to pull it off. A lot of them get upset because they're used to doing it for years, but we also let them know that if they start eating healthy, even though if they don't know that they have it or they're in risk, they can also change to let them know that, okay, maybe if I do this a little different, then I might can prevent something from happening. And it also goes along with a lot of with high blood pressure, cholesterol, all other stuff that a lot of people that don't know that they have or could be at risk of would be able to.
All right. So this partnership that we have with Bon and Tricycle Garden, it's a cooking class as well. So the participants get an opportunity to prepare meals from a recipe, and then they get to prepare the meal, and then, of course, at the end, they get to eat it. So it's an 8-week course, and at the end of the 8 weeks, they will have a cook-off. So there'll be one person in the class who is the winner, and they will win a whole new, brand new cooking pots and pans for their effort. So now I'm gonna turn it back to Ms. Stephanie Tony.
Thank you, Denise. And so on this slide, we just have it's an infographic, essentially, to just kind of, in a picture, try to give us a synopsis of our resource center model. And so we have a patient that comes into the resource center. On a clinical day, we're able to provide family planning services, STI screenings, and then in the context of the visit, kind of depending on their risk factors, we do a glucose screening. And so we'll get to that in a minute, the actual tool that we use. But the public health nurse in clinic is able to do that screening and identify if there's a need for additional resources. We talk about the family history, the person's demographics, their personal history as well as their family history, and we're able to identify their risk factors. And then we talk to them more about, do you have a primary care doctor? One of the questions we specifically ask is, have you seen a primary care doctor within the last 6 months, or have you visited an ER? So we ask the have you visited an ER because sometimes they use that as their primary care physician instead of having one specific for that. And so we talk about a primary care doctor is essential and important, and usually during that annual exam, if there's certain risk factors, they would do a hemoglobin A1C to be able to identify if you're pre-diabetic or if you're in the area of diabetes, so that things can be addressed with medication or lifestyle changes as far as diet and exercise. And so because we ask that question, we are kind of challenging them to get one if they don't already have them. And then in clinic, if we identify, no, they don't have a primary care doctor, or they've utilized the ER for that service, we will connect them with the community health worker in order for them to establish a primary care relationship. One of our community advocates had mentioned the idea of a primary care doctor. So the emergency room is like a Band-Aid to kind of deal with the situation at that time, but just put a Band-Aid on it. But the primary care doctor is able to kind of dive into that wound and really address it and make sure that things are healing from the inside out. And so reminding them of that analogy so that they can be reminded to try not to use the ER unnecessarily and to connect with a primary care doctor. So that diabetes is usually something that everyone is kind of aware of, but is not sure how it relates to them. So us even using the language or bringing up in the context of the clinical visit helps us to identify their need. social determinants of health, this slide kind of shows the 31% of people that are coming to our clinic for clinical services, but they have almost 70% other needs. And so to provide holistic care, our community health workers are essential in helping us to meet the greater need, really. And so a lot of times, especially as a public health nurse, I am, focused on health. I want you to be healthy. I want you to be well. However, like, you're focused on, hey, I need a job. Like, as much as I want to get a primary care doctor, I don't work right now. I need to provide food. And so as much as it may be a priority for me to link them with that care, they're really focused on that job. And so the community health worker, of course, the debate was to bring them in for clinical services, but while we have them on the hook, let's try to address all these other things that you can do well holistically. The whole being is well. Linkage to care, and so we have, in order to provide proper linkage to care, we have identified some areas to make it a successful process. So identifying participating medical homes in our area, establishing MOUs, memorandums of understanding, designating agency personnel so that I can call Rachel at such and such organization in order to help this client get in for an appointment. Training our staff to be effective and communicate in layman's terms, not with a whole bunch of medical jargon, but in layman's terms, what the need is. And then referral tracking. So referring, we're going to talk a little bit more in just a moment, more about how we track our referrals. And so being able to document well what's going on with that client. So as the public health nurse identifies the need in clinic, they're able to document in the system to be able to hand it over, like make a warm handoff without specifically giving a summary to the CHW for each client. So that tracking is certainly essential. Our system that we use is called CHW Care Connect. And so we also have identified 2015 service profile. And so every year we do a profile to identify kind of what we've done during that year. And so this is a summary of what we did last year. And the specific areas, there's a lot of information on this sheet, but the specific ones that I'm going to touch upon is chronic disease, referrals for health and social services, as well as referrals and navigation to a medical home. And so chronic disease is something that we're identifying in clinic. We're taking blood pressures, and so we had over 1,300 people that had their blood pressure checked. And so out of that could derive abnormalities as it being too high, and that's a great opportunity, or segue into, do you have a primary care doctor? And then the blood sugar screenings, some people are a little bit more hesitant to do the blood sugar screening just because it involves a needle stick, and some people just kind of don't want that. But as we are able to identify those, over 66, we were able to identify and be able to talk more to what that number means. So we explained to them, the blood sugar screening is just a snapshot of right now, and then when you get to the primary care doctor and they do a hemoglobin A1C, that further identifies, like, over the 3 months, do you have a history of this high blood sugar? And so we were able to do that in 2015. Referrals for health and social services, so we were able to, the number of referrals from our CHD staff to other resources is over 1,500. The number of community agencies, so over 1,500 people were referred, and that was to 175 different agencies in Richmond. Referrals and navigations to medical homes. So this is kind of a key area that I'll touch upon a little bit more. So we had 205 patients that were referred to medical homes. Out of those 205, we had 95 that were able to make it to their initial appointment. So that's 46% of them that were able to make it there. And that just continues to affirm the importance of the CHW in order to make that linkage. So a lot of times if I just give you the information for you to go somewhere, you're like, oh, I'll get to it. But the CHW is able to effectively follow up and make sure that they actually go. And if there were barriers that hindered them from being able to go, what were they? Let's talk more about setting up another appointment and really holding them accountable or empowering them to make that connection in order to have the services provided to them that they need. So this next tool is what I was mentioning to you, CHW Care Connect. It's a tool that we are using in order to document our referrals. And so in clinic, the nurse will document if she's referring to a client, that initial referral. and then the community advocate is able to kind of pick up where we leave off in clinic. So I'll give it over to Shantini to speak a little bit more about our documentation tool.
Thank you, Stephanie. So the Care Connect is a very important tool for all CAs. We utilize this resource as a way to track our clients' needs. We also organize our outreach efforts. We manage and document our caseload, follow up with clients, data research specifically to the area where we are or the clients that we serve. For example, we have car seat class, we have diabetes management, we have seasonal programs such as holiday services and or partner resources. So that system in itself help us identify and serve clients with that particular need. And it also help us keep track of what their needs are and ultimately be able to follow up. We need a system that can assist us not just in doing the job, but also where we can document the information for further support or fact-seeking efforts. And with that being said, I'm gonna pass it over to Stephanie so that he could share more.
So I had alluded to the tool that we use. So we have this pre-diabetes risk screening tool that we use. It's on a larger sheet that includes the screening for that day, the actual value of their blood pressure and their blood sugar if they got that done. And so I extracted a piece of this form that we use that specifically writes out specific questions in order to identify their score. So 3 to 8 means probably low risk of having diabetes. Obviously, we're not diagnosing anyone, but if they're overweight, they need to lose weight. There are certain things that they could be doing to continue to improve or keep their risk at a minimum. And so if their score is 9 or more, that's when we would identify additional resources for them to connect with. So we have local agencies that we're able to refer someone to for additional diabetes education, not necessarily saying that they have diabetes, but how about you get some more, that's what we would send to a cooking class or something to be able to help minimize their risk factors, and definitely connecting them with a primary care doctor to get that hemoglobin A1C completed to identify if indeed they do have diabetes and need to be on medication. And so that referral process is really helpful for us to identify if there's an educational need in addition to the medical need to actually connect them with those resources. So in clinic, we will do this tool. The public health nurse will actually complete this tool, identify the score. We also at community events will use this tool as well as we are seeing clients and doing screenings, which has proved to be really helpful. So someone may never actually physically come into our clinic, but because we're going out and doing the community outreach and community events, we're able to still connect with lots of people that may have a need or may be underdiagnosed, and we're able to connect with them. So bringing the tool to them has proven to be helpful as well. I'll lend it over to Denise for her to add additional insight.
So one thing I think is very important when Richmond City Health District decided to go back into the community and provide this service of clinic and social determinants of health services, we realized that we definitely needed to hire folk from inside the community. And that has been key to the success of what we do. I need to mention that all that wonderful work that you heard, my staff only work 25 to 28 hours. So they're not full-time. They are doing this in part-time, and they're able to accomplish some great numbers in terms of the work that they're doing. So I thought that was very important that you know the reality of what their workload looks like and how they are able to accomplish the goals within the hours that they are given. Yeah, I'll lend way to Ms. Stephanie to give you the conclusion.
Thanks so much, Denise. I'm really glad that you brought that up because it's definitely, there's a great need, and providing this service is essential. And so I don't think we can say it enough that the community health worker is essential to our success in order to effectively serve the community. Like we can, as a nurse, I can focus on the health, but all of these other things, I need someone else to be able to tackle it and address it and acknowledge it. So even, we may not be able to address everything because there's a lot, right, to unpack and deal with, but even having that partnership or having that coach or that person that's encouraging and empowering has proven to be really helpful. So we're just circling back to this same slide to identify just this circle of that we're just trying to close the gaps and bridge the gaps that we have in the community. So getting to the client, if the client never comes to the clinic, making sure that we meet them wherever they are. So if they're at a community event, if they're at a store, if they're at a church, if they're at the library, we are going to the places where the people are, not just sitting in the clinic waiting for them to come to us. And the community health worker is essential in that momentum that continues to build surrounding our movement to make sure that we are serving the population's health. And so, yeah, I think that's it. Does anybody else have anything else that they would like to add? All right, so we're going to give it back over to open up for any questions that may have come up while we were speaking. Thank you so much for your interest and your time.
Thank you so much. This has just been incredibly impressive, the team that you have, the work that you're doing. And we're going to give people just a couple minutes to pose some questions to you guys. But in the meantime, while we're waiting for some questions to come up, as I think, Abby, you had mentioned earlier about, every state is in different phases using or tapping into this incredible workforce. And I guess just from all of you, from your standpoint, what's really been some of those factors that have really helped shape your program and continue to expand it and have positive impact on your community? You've mentioned some of that, but what are things that really stand out for all of you?
Well, I could say for sure from IPHI's perspective, I think one of the critical pieces is having a strong partnership. That has been extremely important for us. The team talked about CHW Care Connect, which, as we think about the roles of public health nurses and CHWs, having that tool to communicate across the spectrum of from the time a client walks into the clinic to when they are referred in to other services, to be able to track their progress through the program, even when they leave the program, to ensure that they've been achieving certain outcomes. Having that tool is critical. And what we're seeing and what the data shows nationally is that for CHWs to be effectively integrated into care teams, there needs to be effective communication. And effective communication, when you have people out in the field, when you have some people in an office, definitely you need an effective electronic health record or some sort of electronic system to facilitate that. And IPHI manages that tool and helps to build that out with input from our CHD, and it's constantly evolving. But our partnership is effective because we have those sorts of tools to facilitate communication. So that's one of the pieces that I would really want to highlight as an important factor to the success of this program. And I'll pass it on to anyone else.
Well, for Denise, I would also include the fact of developing the Community Health Workers Association to really build their workforce. We've done some speaking to the health legislation to move this movement forward. It's important. It's an important element to the success of really developing those prevention measures that we desperately need, especially in the community in which we serve. The community health worker is essential. And in order for them to continue to be essential, especially in Virginia, which we did not accept the expansion of Medicaid, so in terms to be able to fund them, we have to push this movement. And the movement must be pushed in terms of the community health workers getting paid the value of the service that they render. And so that's my piece.
Yeah. And I would definitely add on to that, that as the public health nurse, just having respect for the role, just recognizing that we can't do it by ourselves. Like we just don't have the capacity to be able to serve the need. So just recognizing that there has to be that type of respect for the role, even though it may not be defined with specific accreditation right now, just knowing how vital it is to our success and to the client's success. So the overall success of the agency, right, to serve the need, but essentially to the client's success to be able to do that empowerment that is required. So I can give the education and provide it about diabetes, but what then? Like, you're going to have to go back to life. You're going to have to meet those needs. And how do you incorporate what you've learned into your life? And the CHW is vital in making that actually happen, making that actually stick, so that when you're teaching your children, this is generational change that's happening because you've learned it from us, and the momentum continues to build.
Well, I would like to add from the advocate perspective is that we are diverse. We come from a diverse group of people. We come from diverse socioeconomics. We come with diverse skills and knowledges, values too. So that help us be able to reach and be able to connect and be able to build that relationship that is unique with our community. We are able to connect with each other as fellow associates. We're able to connect with our medical and clinical staff because we know what our needs are, and we share them with the professionals who are able to assist. So I think that's collaborative effort, and it helps us be able to reach everyone, not just one group of people, but it helps us reach more people.
And for me, Shakita, it's like I like the way that they try to do it, where they try to get someone out of the community to work for the community, because it gives them the level of education on knowing where some people stand and everybody is in a certain place because of certain reasons. And we don't talk down on a person. We meet them at their needs. And it's like, because we have been through some of the things that they have been through, we can kind of understand what's going on and not be like, knock on their door, okay, because we're up here and you're down here, you know. So it's like we kind of meet them on that level, and we kind of understand some of the barriers that goes on, and we let them know, okay, I done been through some of this, so kind of make the door open a little bit so they can kind of give us that trust and understanding and know that we're not there just to like get on them for this, that, and the third. We're getting on them to help them. And, you know, I always call it being that parent. You know, being that parent, I'm going to make sure that I'm going to be that parent that's going to keep sticking to you to go to your appointments, make sure you do this, that, and the third that you're supposed to do. So anytime you hear me say that parent, is in a good way, not a bad way. So, yes, I kind of do that with my community to make sure that they do what they need to do.
Thank you so much. You mentioned communication, partnerships, professional associations, just having the diversity of the workforce, knowing your community and your individuals and understanding those needs. I think that is incredible. So thank you for sharing that. We do have another question that came through from Suzanne Holly. It's clear that the CHW role is critical. Are you or might you collect data about who or what contribute to better health of health-seeking behaviors?
Yeah, so I think that's a question for the public health nurse, because sometimes we're the first one that kind of comes in contact with them if they came in for clinical services specifically. And so I'm just going to read your question again to make sure that I'm going to answer it accurately. But are you or might you collect data about who or what contributes to better health for the reason they're seeking behaviors? So what I gather is, please clarify if this is inaccurate, that you're asking, do we identify why they're seeking care in the first place? So I'm going to answer it that way, but if that's not what you're asking, okay, great, that is what you're asking. Wonderful. So a lot of times we identify, I guess once they find out that we're there, they're like, sometimes people come and go. And so us even being there for over 7 years has really just lent itself to trust. And so even if they may not know exactly what we offer, they're coming in the door inquiring, and they're curious, and they're trying to figure out more about what is this resource center. You guys have been here day after day, y'all are always out here providing services, connecting. What's really going on? So on a couple of different levels, people find out about us usually through word of mouth. So as the word of mouth continues to spread that we're doing a great work, that we've got community health workers that are providing the linkage to care, we're finding that more people are coming in the door because of word of mouth. So usually that's why they're seeking something. They may not specifically be seeking a specific service that we have to offer, but they're coming in the door out of curiosity. Once they're in the door, we're like, well, do you have a job? Do you want to get better education? Do you need clinical services? We offer family planning services. We're doing STI screenings. We're giving them all the information on what we have to offer, so they have a list of options that they can choose from for things that they can say, oh yes, I do need that. I'm so glad that I came in and connected with you guys because I do have a need for this, or I have been thinking about changing jobs. Can you help me with my resume? So there is usually, there's a variety of different reasons people come in. Usually it's by word of mouth, and usually it's because of curiosity or clinical services specifically.
And we capture all of that in and all of that information is captured in the Care Connect. So that would be considered a referral, and each CA is to follow the referral up until 2 months. If they cannot make connection, then they would change the status of the referral to incomplete. But that doesn't mean that if the person comes back in, we can't open that referral again. We can. And so whatever they're seeking, we are always capturing that data in the database that we have.
Thank you so much. And Suzanne replied that it's great, and sharing your success is both educational to other communities and inspiring too. Thank you. So we have another question from Verna Lavoie, and she said, I applaud your state in embracing and supporting CHWs. I reside in the state of Missouri. CHWs are new. They are beginning to use them in Kansas City, Springfield, and St. Louis, the more metropolitan communities. I'm in the center of the state, Columbia, Missouri, where we have just launched a prevention health initiative for the Black community through the Black church setting. I have 20 church communities engaged. Side note, Medicaid expansion has not passed in our state. Any ideas who to partner with to support the CHW movement in my community?
This is Denise. And we have looked at you guys on program because we're working on certification at this time. And so we have reviewed y'all certification process. We have partnered with, if you have local grant funders, connect with them. You want to definitely get familiar with your legislators. And then other organizations like United Way. Is no organization that you cannot partner with.
That's right.
That's just take it at the whole, because somebody got something that they can offer to what you're trying to achieve. And the more people that you engage in knowing what you do and what you're doing, the better off you will be in terms of moving the movement. So those are all the things that we are engaging with here in Virginia, and as to further investigate all of the other states that already have these things in progress. There's no need of reinventing the wheel. So if you utilize what's already out there and you take those components that meet your need, always remember the need of your state may be different from somebody else. So all of the components you may not be able to use, but the ones that you can, you utilize those to meet the needs of the people that you are serving.
Yeah. From a partner perspective, as we were starting out some of this community health worker work, we identified some of the fields that have traditionally used volunteers and peers in their outreach efforts to address health issues. So we found that organizations that do HIV prevention and care in communities have, from the beginning of the HIV epidemic, utilized and worked with people living with the virus and peers, people affected by the virus, to do the work. So getting them on board as well, with recognizing that peers are valuable to the health system, can be a critical partner for this work. There are many organizations that work with volunteers to do outreach, health education in communities, seniors. Those are great organizations to partner with as well. Free clinics. From a funding perspective, we have found that working with some managed care organizations has been beneficial because through the Affordable Care Act, there are different standards that managed care organizations are being held to ensure that they're meeting the needs of their members or patients. Working with the Medicaid office, even in a state that does not have Medicaid expansion, the Medicaid office is a critical partner to the advisory group. And we've touched base with them at multiple times to share our efforts and how we are progressing with developing community health workers. So there's multiple different partners that you could reach out to.
Any other organization would be your hospitals, because they can employ your community health workers. And so the more that they are engaged and see the reality of how beneficial a community health worker is, the better off you will be.
Yeah, and I will just add the hospitals, just piggybacking on that, that a lot of times they don't, so as much as they are about money and seeing patients, when they get those that are revisiting their hospital unnecessarily, the cost, it gets skewed. So just reminding those hospitals about the importance of this on the prevention side to prevent them from ever coming in the door unnecessarily, and prevent yourself from getting sick. And so the hospitals is definitely key to have them on board with this partnership to see that the work that's happening. It's hard to count what you've prevented because it never happens, right? So how do you count the people that didn't visit the ER? And so that's a little bit difficult sometimes to actually collate a specific number, but it's definitely helpful to have them in the conversation or have them at the table as a key stakeholder because they're seeing the same clients that you're serving.
Very good. I see there's two more questions. Great, questions are coming through.
Yeah.
One is on the social determinants of health, and whether as CHWs or as a system, a program, are there things that we do outside of linking our clients to services? Are there ways that we work together to mobilize key stakeholders to address gaps in local resources? So, and if I want to make sure I'm getting this question right. So, for example, we know that transportation is a huge barrier for many of our patients. Does it make sense to just provide a referral to transportation, or have we ever attempted to mobilize key transportation stakeholders to think about, all right, how are we going to even address the fact that there is no transportation in Richmond, right? Is there anything like that we've done so far? Or I know that's something that we've discussed, and through a couple of the grants that we've written, we're trying to think more so how we could increase, better communication across referral providers, but I don't know, have we done anything like that?
So we have done some stuff with transportation. Something as simple as getting an additional bus stop that stops close to where they live and not having to walk 10 blocks before they get to the next bus stop. So we have done some of those things to guarantee bus stops are close to where people live. And at most of our complexes, the bus does stop within a good radius so they don't have to walk real far. So that's one thing.
Also being at the table when those conversations are being made.
Right.
A lot of times organizations forget to have the actual person that's going to be receiving their services at the table. And so just always being mindful, have a CHW at the table. They live in the community. Having another resident at the table, somebody that's actually going to be receiving the services, is essential because they're able to speak to, is this feasible?
Right.
So at the organization may think, oh yeah, this makes sense, this looks good, let's do it. But the people that are actually going to be using it is like, no, that's dumb. Like that doesn't make sense. But they were never consulted. So making sure, I think we do a really good job of making sure that the right people are always at the table to give voice to who needs to be heard.
Yeah, it may appear as though sometimes for our community health workers, it may appear that we have them at lots of different meetings at different organizations, but it's essential because they know what's needed. They know what the people need, and so it's essential that they be at the table. Nobody wants to come to the table after everything has already been decided.
Okay, thank you so much. I guess we have one more question that we can take just another minute. I know that we're running over, but we'll take one more minute and see if we can address the question of if the community is not working with CHWs, how can we do our job as a role of CHW, because we are working for them, trying to make this community better health wise and understand how important is their health.
So the community not working with you.
Is that as in the residents? Or
Yeah.
Elaborate more on your question so we can get clarity. But I think we'll try to answer the question to say, if you don't have community health workers, how do you still, like as a community health worker, how do you still build momentum surrounding that? Is that your question? Yes.
Yeah.
Okay. So I'll let
whoever wants to say.
Okay, I'm Shakita. As far as getting your community to work with you and you working with your community is really going to be a process. It's not going to be like when you first go there, they're going to have trust in you. You have to get their trust in order for them to like give you any information. And see, my problem was I had my badge on. So no one wanted to talk to me with my badge. So I had to like literally put my badge in my shirt, but still have it on and just talk to them at their level. Some guys is easy to talk to, some girls is a little tricky, but you have to work with the community and figure out where can you meet them at to talk to you. Sometimes you can go up to them while they might be standing at the bus stop and just carry on a general conversation. You carry on a general conversation with them and then they will open up to you a little bit. But as they start to see you more out in the community, doing your job and seeing little resource that comes in the community, then they will open up to you a little bit more. Now, I'm going to let you know, once they start opening up to you, that's going to be it. You're going to get more information than you actually want, but it's helpful because you know what that person needs. And maybe they might be talking about them and might not know that they have an issue or something, but you can pick up on certain things that they are saying to you. Letting them know, then you know that, okay, I just don't need help with diabetes. I need help with a PCP. I need help with, getting food, the kids, just general conversation, and then you can go from there. But it's not going to be easy, but once it get easy, you can go on, just walk out your car, go to the building, they're going to be standing right there at the door waiting on you. So it's hard for the beginning, but after then it's going to get a lot easier for you.
And I'd also quickly add that a lot of times you may be able to find out who the leaders are in the community, even though they don't have a title. Like, who do other people follow? Not to say everybody's following someone as a leader, but who can give voice to what's happening in the community? If you can find that person who goes to the association meetings or tenant council meetings, who is usually on the porch, or there's a lot of people gathering around their home, or you see them at a lot of different events, they're networking, they may be a good person to partner with that may already have the inside scoop on the community. And so that may help build your momentum, or partnering with other key stakeholders in the community that already kind of know intimately what's going on.
Relationship.
Mm-hmm.
And from a data perspective, it's good to look at what your community is doing right now and how is that going to help you, because those are ways or avenues. So maximize what is already going on. For instance, if you already have a good program with diabetes, just promote that, or actually if that's the need in your community. So focus on things that your community needs so that they will be engaged and involved. And from a cultural perspective, being that we are so diverse, use those skills to help them accommodate. For instance, in my community, I use Spanish as my engaging connection. So I'm able to reach them more on a cultural basis because that's what they need. Whereas in other communities, I'm going to have to structure it for that particular. So again, looking at your data will help you, but also using and identifying what those needs are will help even more to reach the needs and be able to efficiently service. And like Shakita said earlier, when you get them, you have them for a lifetime.
Oh, thank you so much. This has been a fabulous discussion and a highly informative presentation. I thank you, Abby, Denise, Shakita, Stephanie, and Shantini for your presentation today, for working with us to get this all ready to go, and for being a part of the Mid-Atlantic Public Health Training Center, which is one of our sister centers under the Public Health Learning Network. So it was great to have you. It's very, very good information. And we did post a contact email for Abby Charles that you'll see show up in the chat box. We will have the archived version of this presentation up and posted at www.mphtc.org. If you registered, you will receive an email to let you know when it's been posted, the archive version, and also included in the email, we will have an evaluation of the seminar, and we ask that you just take a few minutes to fill that out when you receive the survey, and we hope to use your feedback to help us enhance future webinars. With that, in closing, I just want to thank you again and hope that you all have a wonderful afternoon.